All right, hi guys, good morning everyone. So today here we are to discuss the SQUINT questions that we had on the EyeMentor app yesterday. I'm sorry, on the Telegram group that we had yesterday. So shall we start with the questions? All right. So the first question is regarding forced duction test. Okay, FDT. Forced duction test is used to differentiate. See, the word duction means uniocular movement, one eye movement. One eye definitely does not move by itself alone. So it's always a binocular movement. So when I say duction, it means uniocular movement, one eye movement. Yeah. So a combination of this duction, that is when you got your gazes, your versions and everything. Now, forced duction. So I am going to force this uniocular movement in my patient. Okay. That is forced duction. Is that clear? So forced duction test. So FDT, right? So when do I do this FDT? To differentiate between. So when I pull, if I feel a resistance or do I not feel a resistance? So that is my end point. Yeah. So when will I feel a resistance or a tug? I will feel a resistance or a tug when there is a restrictive squint. Yes. And when will there be a free movement? When there is a paralytic squint. So I do this FDT to differentiate between a restrictive squint and a paralytic squint. So let's see where that option is. Option A, concomitant squint and incomitant squint. No, right? See, both restrictive and paralytic squints come under incomitant or non-comitant squints. So that is not the answer. Option B, paralytic squint and restrictive squint. Yes, that is the answer. Concomitant squint and pseudo squint. See, pseudo squint is when you get due to an epicanthal fold. You know, there's a epicanthal fold and that gives the appearance of an esotropia, pseudo esotropia. You don't have to do a forced duction test for it. For that, all that you need to do is a Hirschberg test. So if your Hirschberg test is centered, then there's no problem at all. You don't have to resort to, topically anesthetizing the eye and pulling the eye with a eyeball with a forceps and doing this forced duction test. You don't need to do it at all. Latent squint and manifest squint. Guys, latent squint is a phoria and a manifest squint is a tropia, and that is not differentiated using FDT. All right. Okay. So shall we move to the next question? Intorsion is the primary action of. Intorsion, I-N. So you remember that mnemonic SIN, S-I-N, SIN. So superior oblique and superior rectus. But our question is, intorsion is a primary action of. See, for superior oblique, intorsion is a primary action. For superior rectus, it is a secondary action. So our answer in this case is very simple. It's superior oblique. What is the primary action of inferior rectus, bache? Inferior rectus is going to depress the eyeball. Yeah, primary action. Inferior oblique is going to extort the eyeball. Extortion is the primary action of inferior oblique. What about superior rectus? Superior rectus, primary action is elevation of the eyeball. Secondary action is intorsion. Alright. Okay. Next question. Distance between superior rectus insertion and limbus. Yes, this is important. The superior rectus is at the lengthiest distance or the longest distance from the limbus, 7.7 millimeter. Okay, so 7.7 millimeter. So remember superior rectus. Yes, whether it's 6 or 7, give the maximum number 7 and another 7. Okay, 7.7 millimeter from the limbus. Now you might think, ma'am, is this important? Yes, it is important both for your MCQ and practically it's important because that is when you're doing a squint surgery or nothing. Simply when you're starting cataract surgery and you're looking for the superior rectus tendon. Yes, it's 7.7 millimeter there, and that is exactly how your Dasto's forceps also is designed. Okay, so that when you place that bend at the limbus, it will catch hold of the tendon. All right, so 7.7 millimeter from the limbus. I mean, not just superior rectus, for every muscle it is important. All right. What is this 5.5 millimeter? 5.5 millimeter is for the medial rectus. Okay. So again, medial rectus is very, very important because you all do pterygium surgery, right? So when you're doing pterygium surgery, don't go digging too far away from the limbus. Don't go beyond that 5.5 millimeter. Then you might end up damaging that medial rectus, and patient might have fibrosis, resultant consequences. So be careful. All right, the number of cardinal positions of gaze. Okay, there we got you. So the cardinal positions of gaze, guys, totally there are 9 gazes. Okay, so totally 9 gazes. You got an up, down, left, right, then your up and right, up and down. So your dextro elevation, dextro depression, levo elevation, levo depression. Okay, so 1, 2, 3, 4, 5, 6, 7, 8 and straight 9. Okay, so totally 9 gazes. Now out of this, which are your cardinal gazes? Leave out this. Okay, so leave the up, center and down. Everything else comes under cardinal gazes. So cardinal gazes are this one, 1, 2, 3, 4, 5, 6. Okay, like an asterisk. When you put an asterisk, how many points would you have? Yeah, n points. So 6 is your cardinal gazes. So for cardinal gazes, remember your asterisks. Okay, so asterisks you're going to have 1, 2, 3, 4, 5, 6. Right? Total would be 9. Cardinal gazes 6. Is that clear? Okay. All of the following are features of paralytic squint except abnormal head posture. Yes, patient can develop abnormal head posture depending on which muscle is paralyzed. Yes. Amblyopia. Why would patient get amblyopia? Because of paralytic squint? Anyway, let's see. Is there a better option or should we go for this? Diplopia. Yes, patient does have diplopia, right? Yes. Binocular diplopia. Restricted or reduced eye movements. Yes, has a reduced eye movements. Not, I wouldn't really call it restricted. Yes, there is reduced eye movements. That word restricted should not have been there. Reduced eye movements, yes, definitely. So amblyopia, yes, amblyopia is not really seen because most of the times paralytic squint is an acquired squint. In an acquired squint, you don't get amblyopia because you get it at an older age. Now, suppose there is a congenital, absence of a cranial nerve nucleus, and because of that, there is a paralytic squint. Now, in that case, probably there can be amblyopia. Yeah, a paralytic squint very early on in life, and that is resulting in amblyopia possible. But given the options, so what were the other options? Abnormal head posture, diplopia, and reduced eye movements. All these are seen in paralytic squint, and amblyopia, no. All right. Equal innervation of yoke muscles is explained by what are yoke muscles? Yoke muscles are muscles belonging to the 2 eyes. So it's a pair belonging 1 to each eye, and they are responsible for coordinated eye movements. Okay, so coordinated eye movements, those are yoke muscles, so that my eyeballs move in a parallel fashion, so that I look at the same object of interest. Yeah, it's not that one eye looks here and another eye looks elsewhere. So these are yoke muscles, and the yoke muscles have to receive equal innervation, and that is explained by which law? Embutwick law. See, Embutwick law, nothing to do with extraocular muscles at all. It goes to do with your Goldman applanation tonometry. Okay, so that is the principle behind applanation tonometry. Herring's law. Yes, Herring's law talks about equal innervation to the yoke muscles. What about Sherrington's law? See, Sherrington's law talks about reciprocal inhibition. Okay, so reciprocal inhibition of the ipsilateral agonist and antagonist. So if the agonist is getting positive innervation, there has to be a reciprocal inhibition to the antagonist. Okay, so reciprocal inhibition of the ipsilateral antagonist is described by Sherrington's law. Laplace law, not here. Okay, so Herring's law is our answer, which describes equal innervation of the yoke muscles. Okay, next question. Which of the following is a sensory test in the workup of squint? Okay, which is going to assess the sensory adaptations. Hess chart. No, Hess chart talks about the motility range. So it's not a sensory test. Worth 4 dot test. Yes, let's see. Duochrome test, nothing to do with the workup of squint. Duochrome test is for binocular balancing when you're doing refraction. Okay, so nothing to do with squint at all. Prism bar cover test, it's actually measuring your squint. It is not a sensory test, it's an objective measurement of the squint itself, yes, of the motor imbalance. So it's a motor function that we are testing. So the sensory workup is Wirth 4-dot test, because we are seeing if the patient has binocular vision. Yes, binocular vision is a sensory feature, no? And we are looking for anomalous correspondence, we are looking for suppression if any. Yes, so all these are sensory adaptations to squint. So Wirth 4-dot test is a sensory test in the workup of squint. But have you all understood this point? Wirth 4-dot test is a sensory test. Okay, so we got motor tests and sensory tests. Hess chart is to assess the motility range. Your prism bar cover test is to find out how much is the squint itself. So that again is looking for the motor, is evaluating the muscle, right? Yeah. Next question, a patient with manifest squint has no complaints of diplopia. This may be due to. So patient actually has tropia. There is a squint. You're seeing the patient has a squint. Toing, toing is there. But you as a patient, do you have any diplopia? No, patient has no diplopia. Why is this? Fusion. See, fusion is a second step of BSV, binocular single vision. For that, first he has to have simultaneous macular perception. Yes, SMP. So SMP is possible only when your eyes are aligned. His eyes are not aligned because they've told in the question there is manifest squint. So fusion is possible only if you and I have straight eyes. So fusion is not the mechanism why this patient with a manifest squint is not reporting diplopia. No. Abnormal retinal correspondence. Yes, that is the answer. I'll come to it. Secondary deviation. What is the definition of secondary deviation? Secondary deviation is when your squinting eye or the deviated eye is assuming fixation and then you look at the squint. Yes, the amount of squint. Yes, you chart that. That is secondary deviation. Nothing to do with this patient not having diplopia. Null position is to do with your nystagmus. Null position is some position of the eye or the head at which the nystagmus amplitude is the least and the patient sees very quite clearly, the best clarity or the best visual acuity in a nystagmus patient, nothing to do with squint. Okay, so abnormal retinal correspondence. So that means fovule of one eye and an extrafoveal region of the other eye, they become corresponding points. Yes, and the brain adapts to this. Yes, otherwise normally we have corresponding points in the retina. Yes, now when a patient develops early squint, in childhood, very early in childhood, they do develop this abnormal or anomalous retinal correspondence where non-corresponding points of the retinas become corresponding. Yeah, so that is called abnormal retinal correspondence. So the brain now does not appreciate diplopia. It sees as single vision. That is why in some cases in Wirth 4-dot test, when we do, the patient has a squint and you're showing him the Wirth 4-dot test and he sees only 4 dots. He neither sees less nor sees more. Okay, so he doesn't report 5 dots at all. If he reports 5 dots, yes, he's got a squint and a diplopia. Squint and no diplopia, some mechanism, and this patient is reporting 4 dots on Wirth 4-dot test just like a normal individual. But you see that he has a squint, that means he has developed abnormal retinal correspondence. Is that clear, bache? Give me a thumbs up if you understood this. Let's move on to the next question. Accommodative esotropia may be managed with. This is time and again repeated question. Accommodative esotropia is seen very commonly with hypermetropes and it can be managed with spectacles. It can be managed especially with pilocarpine. Pilocarpine is going to saturate that parasympathetic mechanism. So it's going to overwhelm your convergence mechanism. So the patient cannot converge for the eyes to go into esotropia. Is that clear? So that is a basic mechanism. There is a detailed video I put up on YouTube. You can go and search as accommodative esotropia Rajarathna on my channel and then you will be able to find it. Okay, so I'm not delving deep into that. So the other options were atropine. See, atropine is the opposite of pilocarpine. No, pilocarpine is a parasympathomimetic which is going to overwhelm the system. Atropine is a parasympatholytic. It's going to paralyze the muscles. I don't want to use that. Okay. Concave spheres, no role. Convex spheres, yes, they do, because it's accommodative esotropia is because of hypermetropia. So if you want to manage hypermetropia, you're going to give convex spheres, right? So convex spheres maybe, but my options is concave sphere, cylinders, no way. Last question, fourth nerve palsy may present with, or in other words, fourth nerve, so and they are asking us all the compensatory head postures. See, fourth nerve, that is your trochlear nerve, supplies your superior oblique, SO4, right? So fourth nerve palsy means it's going to be SO palsy. So SO, let's say in this side, what is the primary action of SO, superior oblique? Intorsion. Yes, intorsion. So just do the same movement with your head, intorsion. So there's a head tilt, yeah, head tilt to the opposite shoulder. Let's see what is given. Head nodding. Why would you have head nodding? Head tilt. Yes. Is there anything better option? They've not talked about to the opposite side. Anyway, let's read the next option. Face turn. No. Ocular bobbing. Now, question for you. Which condition do you get? Ocular bobbing. You'll put it in the comments. Okay. Head tilt is the answer. They've not been specific about the options, just given just a random head tilt, but you know head tilt to the opposite shoulder. Is that clear? So if it is SO palsy here, it will be head tilt to the right shoulder. If I have a right SO palsy, I'll have a head tilt to the left shoulder. Is that clear to everyone? All right. So we are done with these 10 questions, and this evening at 6 p.m. we are going to have a refraction quiz, 10 questions, the discussion of which we will have here on my YouTube channel tomorrow at 11 a.m. Very good, Ram Narayan, very good, good. All right. If you want to join our test and discussion for the INI-CT or the NEET PG or the upcoming PD set, the link to join is given in the description. First 2 tests are free, and then you can take a look if you want to continue with the tests. All right. And what else? There is the February discount coupon is on, and if you want to join any of the courses, you can directly purchase through the app, EyeMentor app, or you can go to EyeMentor.store where you get a lot more discounts. You can check out our website, EyeMentor.store, and you can choose your appropriate courses and apply the discount coupons during checkout. You have to enter the coupons during checkout, and you'll get a lot of discount. And then my team is there to get you the access to the course. All right. So I'll see you guys tomorrow 11. Bye-bye.